Please raise your right hand slowly towards me.
Sorry, I just froze for a moment.
That's quite all right. You can place it back down.
Pathology of Fear is a medical documentary series presenting clinically documented neurologic and pathological mechanisms for educational analysis.
The patient is seated in a neurology clinic exam room, upright but visibly cautious, as if movement requires calculation. A blood pressure cuff rests on the arm of the chair, recently removed after a repeat measurement taken while standing. A sleep study report is folded into the chart. On the computer screen behind the clinician, a recent MRI is open, no acute findings, mild generalized changes, nothing that demands an answer. A patient is in their late 60s. They were referred for cognitive decline, but the history does not move in a straight line. Some days, conversation is clear and organized. On other days, attention drifts mid-sentence. Family members report episodes where the patient appears alert, oriented and engaged in the morning, then becomes confused and withdrawn by afternoon. Memory loss is inconsistent. Names are recalled accurately one moment and missed the next. There is no steady downward slope that fits expectation. The neurological exam does not resolve the ambiguity. Cranial nerves are intact. Eye movements are full. Speech is fluent, though occasionally slowed. Muscle strength is preserved. There is mild rigidity in the upper limbs that appears with distraction and fades when tested directly. Gait is cautious, with reduced arm swing, but balance is maintained. Tremor is absent at rest. Reflexes are symmetric. Vital signs tell a separate story. Blood pressure drops when standing. The patient reports lightheadedness that has been present for years, long before memory complaints began. Constipation is chronic. Sleep is described as violent, with episodes of shouting and striking during dreams. These details sit uncomfortably outside the referral question. The chart documents a history of shifting diagnosis. 5 years earlier, the patient was treated for depression after reporting apathy and low motivation. 2 years later, visual hallucinations prompted psychiatric evaluation. The hallucinations were detailed, but non-threatening: people in the room, animals in the hallway, and the patient retained insight, recognizing them as unreal. Antipsychotic medication was prescribed. Within days, rigidity worsened dramatically. Confusion intensified. The medication was stopped. A year later, a movement disorder specialist considered Parkinson's disease due to bradykinesia and stiffness. Dopaminergic therapy produced minimal benefit and worsened hallucinations. The diagnosis was reconsidered. Most recently, cognitive testing suggested dementia, but memory scores were better than expected. Attention and executive function were impaired, but not consistently. Alzheimer's disease was discussed, then deferred. The diagnosis was left open. This patient is not rare. What is rare is clarity. Lewy body dementia does not present as a single disease state. It presents as a series of partial truths that never align at the same time. Each clinical encounter captures a different aspect: psychiatric, cognitive, motor, autonomic, without revealing the structure that connects them. Medicine is built to recognize patterns that remain stable. Lewy body dementia violates that requirement. The disease does not progress smoothly. It fluctuates. Motor findings appear and recede. Symptoms contradict each other across visits. The nervous system does not fail uniformly. It destabilizes. This instability creates diagnostic paralysis. When cognition fluctuates, clinicians suspect delirium or psychiatric disease. When hallucinations appear early, psychosis is considered. When rigidity emerges, Parkinson's disease is evaluated. When memory is relatively preserved, Alzheimer's disease is questioned. Each assessment is reasonable in isolation. Together, they miss the disease. The problem is not lack of knowledge. The problem is that Lewy body dementia occupies the space between categories. It is not purely cognitive. It is not primarily psychiatric. It is not classic Parkinson's disease. It is not Alzheimer's disease with added symptoms. It is a disorder of distributed failure. In Lewy Body Dementia, the brain does not lose functions in sequence. It loses stability. Neural networks flicker between coherence and breakdown. Systems that should operate continuously instead oscillate. The result is a patient who appears different from one hour to the next. This variability is not behavioral. It is biological. Yet because the disease resists consistent presentation, it resists diagnosis. Each specialist sees a fragment. Each fragment suggests a different label. The disease moves faster than consensus. By the time Lewy Body Dementia is named, years have often passed. During that time, treatments intended for other conditions have caused harm. Antipsychotics worsen rigidity and confusion. Dopaminergic drugs intensify hallucinations. Reassurance based on normal imaging delays recognition. The diagnosis fails not because the disease is subtle. It fails because the disease refuses to behave. This episode begins where medicine struggles most, at the point where symptoms do not align, tests do not decide, and the nervous system will not settle into a single story. Lewy Body Dementia is not defined by what appears on one visit. It is defined by what cannot be made to stay the same. Lewy Body Dementia is not overlooked because clinicians are inattentive. It is overlooked because the disease violates the rules that modern diagnosis depends on. Medical diagnosis relies on pattern stability. Symptoms are expected to cluster, progress predictably, and remain internally consistent. Lewy Body Dementia does none of these things. Instead, it presents as a moving target, changing expression depending on which neural systems are destabilized at a given moment. This creates a structural disadvantage from the first encounter. When an older adult presents with cognitive complaints, the diagnostic framework prioritizes memory loss. Dementia is still operationally defined by deficits in memory encoding and retrieval. Alzheimer's disease dominates this mental model. When memory is relatively preserved, dementia is often deprioritized or deferred. Lewy Body Dementia frequently fails this first beat. Early in the disease, episodic memory may remain intact. Patients recall events, recognize faces, and perform adequately on memory-focused testing. What is impaired is attention, executive control, and visual processing domains that fluctuate and are harder to quantify. Standard screening tools are poorly equipped to capture instability. As a result, cognitive decline is framed as depression, anxiety, or stress-related inefficiency rather than neurodegeneration. Psychiatric symptoms then take center stage. Visual hallucinations, anxiety, mood changes, and paranoia often appear early in Lewy Body Dementia. These symptoms are vivid and distressing, yet insight is frequently preserved. The patient knows the hallucinations are not real. This combination strongly suggests primary psychiatric illness to clinicians trained to separate neurology from psychiatry. Once a psychiatric label is applied, subsequent symptoms are interpreted through that lens. Motor findings complicate rather than clarify the picture. Rigidity, bradykinesia, and reduced facial expression may emerge, but they are often mild, inconsistent, or asymmetric early on. Rest tremor, the hallmark many clinicians associate with Parkinson's disease, is frequently absent. Gait may be cautious, but not frankly unstable. These findings do not satisfy classic Parkinson's disease criteria. Instead of triggering reconsideration, they create diagnostic conflict. Cognitive impairment plus Parkinsonism suggests Parkinson's disease dementia. But in Lewy Body Dementia, cognitive symptoms typically precede or occur within a year of motor symptoms. This temporal relationship is subtle and often lost in fragmented medical records. Without careful chronology, the distinction collapses. The result is oscillation between diagnoses. One visit emphasizes mood, Another emphasizes movement. Another emphasizes cognition. Each specialty approaches the patient from a different angle, applying criteria designed for pure disease states. Lewy body dementia is none of them. Autonomic symptoms are another missed signal. Orthostatic hypotension, constipation, urinary dysfunction, and temperature dysregulation often precede cognitive decline by years. These symptoms are treated as separate medical issues, cardiology, gastroenterology, urology, rather than as part of a unifying neurological process. Sleep disorders are similarly siloed. REM Sleep Behavior Disorder, characterized by dream enactment and loss of normal muscle atonia during REM sleep, is one of the strongest early predictors of synucleinopathies. Yet it is rarely connected to later cognitive or motor symptoms in real time. Sleep medicine and neurology operate on parallel tracks. Each system sees its piece. No system owns the whole. Diagnostic tools reinforce false reassurance. Structural MRI scans are often unremarkable early in Lewy body dementia. There may be mild generalized changes, but no focal atrophy pattern that demands attention. Clinicians accustomed to seeing hippocampal loss in Alzheimer's disease may interpret normal imaging as evidence against neurodegeneration. This is a critical error. Lewy body dementia is a functional network disorder before it becomes a structural one. The absence of early imaging abnormalities does not indicate absence of disease. It indicates that pathology is distributed and microscopic rather than localized and macroscopic. Time variability further undermines confidence. Because cognition and attention fluctuate, patients may perform well during clinical visits. A coherent interview can occur hours after a period of profound confusion. This variability undermines the credibility of caregiver reports and delays escalation. The system defaults to the most stable explanation available. Psychiatric illness is stable. Alzheimer's disease follows a known arc. Parkinson's disease has recognizable motor patterns. Lewy body dementia destabilizes all of them. The diagnosis fails not because clinicians lack criteria, but because those criteria depend on diseases behaving cleanly. Lewy body dementia exists at the intersection of multiple systems and refuses to declare allegiance to any single one. By the time its pattern becomes undeniable, the disease has already spread across networks that no longer compensate. The failure is not one of ignorance. It is one of framework mismatch. Lewy body dementia is not defined by a region of the brain. It is defined by a protein that refuses to remain confined. That protein is alpha-synuclein. Under normal conditions, alpha-synuclein is a small soluble protein concentrated at presynaptic terminals. It plays a role in synaptic vesicle regulation, neurotransmitter release, and synaptic plasticity. It is not toxic by nature. It is abundant, flexible, and normally handled efficiently by cellular quality control systems. In Lewy body dementia, this balance fails. Alpha-synuclein undergoes misfolding. Its structure shifts from the soluble form into beta-sheet-rich conformations that favor aggregation. These misfolded proteins bind to one another, forming oligomers and fibrils. Over time, they accumulate into Lewy bodies and Lewy neurites, the pathological hallmarks of the disease. The critical feature is not the presence of aggregates alone. It is distribution. Unlike amyloid beta in Alzheimer's disease or tau in primary tauopathies, alpha-synuclein pathology does not respect anatomical boundaries. It appears in the brainstem, limbic system, neocortex, autonomic nervous system, and even peripheral tissues. It does not begin in one region and stay there. It propagates. This propagation undermines diagnosis. Alpha-synuclein pathology spreads along neural networks, likely through a combination of axonal transport, synaptic transmission, and cell-to-cell transfer of misfolded protein. The process resembles prion-like behavior, not in infectiousness, but in templated misfolding. Misfolded alpha-synuclein induces normal alpha-synuclein to adopt the same toxic conformation. This mechanism creates staggered involvement of brain systems. One network destabilizes while another remains functional. Symptoms emerge in one domain, then recede as compensatory circuits engage. Later, another network destabilizes. The disease never presents all of its features at once. This is why Lewy Body Dementia fluctuates. Alpha-Synuclein pathology affects neurotransmitter systems unevenly. Cholinergic neurons are particularly vulnerable, disrupting attention and alertness. Dopaminergic neurons are affected, producing Parkinsonian features. Noradrenergic and serotonergic systems are involved, altering mood and autonomic regulation. The result is a nervous system that cannot maintain consistent tone. Attention varies hour to hour. Alertness waxes and wanes. Motor output shifts unpredictably. These fluctuations are not psychological. They reflect variable network engagement under distributed synuclein toxicity. Lewy bodies themselves are not the sole source of damage. Smaller alpha-synuclein oligomers are highly toxic. They interfere with synaptic transmission, disrupt membrane integrity, and impair mitochondrial function. These species are difficult to detect with routine imaging or laboratory tests. Their presence explains why severe symptoms can occur in the absence of dramatic structural changes. The nervous system is failing at a functional level long before tissue loss is visible. Alpha-synuclein also interferes with intracellular transport. Neurons rely on microtubule-based systems to move proteins, vesicles, and organelles across long distances. Misfolded alpha-synuclein disrupts these systems, depriving synapses of resources and accelerating synaptic failure. Mitochondrial dysfunction follows. Alpha-synuclein interacts with mitochondrial membranes, impairing energy production and increasing oxidative stress. Neurons become energetically fragile. Systems that require sustained activity, attention, posture, autonomic regulation fail first. This explains symptom prioritization. Memory encoding, which relies heavily on hippocampal structures, may remain relatively intact early. Attention, which depends on widespread cholinergic modulation, fails early. Visual processing, which requires synchronized cortical integration, destabilizes. Motor control, which depends on dopaminergic regulation, becomes inconsistent. The disease presents as a collection of failures that do not align temporally. This misalignment defeats diagnostic shortcuts. Clinicians expect neurodegenerative diseases to declare themselves region by region. Alpha-synuclein pathology declares itself network by network. Each network fails partially, recovers briefly, then fails again as pathology spreads. This pattern looks psychiatric. It looks functional. It looks inconsistent. It is none of these. Alpha-synuclein does not destroy neurons immediately. It destabilizes them. It interferes with signaling, metabolism, and connectivity. Neurons persist in a compromised state for years. This prolonged dysfunction phase creates the clinical picture of Lewy body dementia variable, misleading and resistant to classification. The protein's ability to exist in multiple pathological forms further complicates matters. Different strains of misfolded alpha-synuclein may preferentially affect different systems, influencing symptom dominance. There is no single Lewy body dementia presentation. There is a spectrum of synuclein toxicity. Because alpha-synuclein pathology is distributed, early disease does not resemble advanced disease. By the time cortical involvement is widespread, diagnosis becomes easier, but also too late to alter trajectory. The protein that defines Lewy body dementia does not create a clean syndrome. It creates instability. It creates fluctuation. And it ensures that by the time certainty arrives, damage has already accumulated across systems that cannot be rebuilt. One of the most defining features of Lewy body dementia is not memory loss, hallucinations, or Parkinsonism. It is instability. Cognition does not decline in a smooth arc. It oscillates. Patients are lucid 1 hour and confused the next. Attention sharpens, then collapses. Alertness varies dramatically from day to day, sometimes from moment to moment. This fluctuation is not incidental. It is the direct consequence of how alpha-synuclein pathology disrupts brain networks. Cognition is not produced by a single structure. Sustained attention, awareness, and executive control depend on distributed neuromodulatory systems that maintain global brain state. These systems are particularly vulnerable in Lewy Body Dementia. The cholinergic system is central to this vulnerability. They regulate attention, arousal, and the ability to sustain cognitive effort. Alpha-Synuclein pathology disproportionately affects these neurons early. When cholinergic tone drops, attention becomes unreliable. This loss is not constant. Cholinergic neurons do not fail all at once. Synaptic dysfunction fluctuates as alpha-synuclein burden varies across networks. The result is a brain that cannot maintain stable arousal. Attention waxes and wanes independent of sleep, motivation, or mood. This produces the hallmark cognitive fluctuations of Lewy Body Dementia. Memory storage may remain intact during early stages because hippocampal structures are not the first to be affected. When attention is sufficient, the patient can encode and retrieve information. When attention collapses, performance deteriorates. This inconsistency is misinterpreted as poor effort or psychiatric interference. Executive control is similarly affected. Frontal networks rely on consistent neuromodulatory input to coordinate planning, inhibition, and task switching. When these inputs fluctuate, executive performance becomes unreliable. Tasks are performed accurately at one time and abandoned at another. This variability resists traditional cognitive testing, which assumes stable performance across sessions. Visual processing further exposes network instability. Visual perception requires integration across occipital, temporal, and parietal cortices. Alpha-synuclein pathology disrupts these connections unevenly. Visual scenes may be processed accurately at one moment and distorted the next. This contributes to visual misperceptions and hallucinations. The brain attempts to compensate. When one network falters, others temporarily assume its function. Increased effort, environmental structure, and familiarity can improve performance transiently. This compensation creates the illusion of reversibility. It reinforces the belief that symptoms are psychological or situational. They are not. Compensation is metabolically expensive. As synuclein toxicity spreads, compensatory capacity diminishes. Fluctuations become more extreme. Periods of clarity shorten. Periods of confusion lengthen. Sleep disruption amplifies instability. REM Sleep Behavior Disorder, common in Lewy Body Dementia, reflects early brainstem involvement by alpha-synuclein pathology. Loss of normal REM atonia leads to dream enactment and fragmented sleep. Poor sleep further destabilizes attention and cognition, compounding daytime fluctuation. Autonomic dysfunction contributes as well. Even brief drops in blood pressure can impair attention in a brain already operating near its threshold. These transient hyperperfusion episodes worsen cognitive variability and are often misattributed to aging or medication side effects. The combined effect is a nervous system that cannot maintain baseline stability. In Alzheimer's disease, cognitive decline is gradual and predictable. In Lewy Body Dementia, decline is erratic. The patient's best moments may look deceptively normal. Their worst moments may resemble delirium or acute psychiatric illness. This inconsistency undermines caregiver credibility. Clinicians often encounter patients during periods of relative clarity. Reports of severe confusion or hallucinations may seem exaggerated or inconsistent with observed behavior. This delays recognition and intervention. The fluctuation also creates false reassurance. When performance improves temporarily, both patients and clinicians may believe treatment is working or disease is regressing. Fluctuation is not improvement. It is instability. At the network level, Alpha-Synuclein pathology undermines the brain's ability to sustain coordinated activity across regions. Neurons may remain alive, but their communication is unreliable. Timing fails. Synchronization breaks down. This instability precedes structural loss. By the time cortical atrophy becomes apparent, fluctuations often diminish, not because the disease has stabilized, but because networks have collapsed entirely. Variability gives way to permanent impairment. Understanding fluctuation is essential to understanding why Lewy body dementia is misdiagnosed. The disease does not behave like dementia as it is traditionally taught. It behaves like a system that cannot hold itself together. This is not confusion layered on clarity. It is clarity fighting instability. And as alpha-synuclein pathology spreads, instability always wins. Visual hallucinations in Lewy body dementia are not incidental symptoms. They are not medication side effects. They are not expressions of primary psychiatric illness. They are among the most reliable early indicators of the disease and among the most consistently misunderstood. The hallucinations of Lewy body dementia have a distinctive profile. They are visual rather than auditory. They are detailed rather than vague. They recur with similar content. And in early stages, insight is often preserved. The patient knows what they are seeing is not real, even as the images persist. This combination should narrow the differential diagnosis immediately. Instead, it widens it. In psychiatry, hallucinations are typically associated with loss of reality testing. In Lewy body dementia, reality testing often remains intact early. This creates confusion. The hallucinations appear psychotic, yet the patient does not behave psychotically. Clinicians resolve this contradiction by assuming psychiatric illness with atypical features. The origin of these hallucinations is structural. Visual perception is not produced by the occipital cortex alone. It depends on coordinated processing across occipital, temporal, and parietal regions, integrated with attention and contextual filtering. Alpha-Synuclein pathology disrupts this integration unevenly. In Lewy body dementia, visual association cortices and their connections are disproportionately affected early. Primary visual input may remain intact. The problem lies in interpretation and integration. The brain receives visual signals, but cannot reliably contextualize them. As network stability fluctuates, internally generated imagery competes with external input. Under normal conditions, top-down inhibitory control suppresses irrelevant imagery. In Lewy body dementia, this suppression fails intermittently. Visual constructs are released into conscious perception. These hallucinations are often complex. Patients describe people sitting in chairs, animals moving through rooms, or figures standing nearby. The images are well-formed, not abstract. They often appear in low-light conditions or during periods of reduced alertness, when attentional control is weakest. This specificity reflects cortical involvement rather than brainstem pathology. The hallucinations are not dreams intruding into wakefulness. They are not delirium. They are the product of visual networks operating without adequate regulatory oversight. Cholinergic dysfunction amplifies this effect. Cholinergic projections modulate visual attention and suppress irrelevant sensory noise. When cholinergic tone drops, the threshold for hallucination lowers. Visual cortex activity becomes less constrained. The brain fills gaps in perception with internally generated content. This explains why hallucinations worsen with fatigue, illness, or medication changes. Importantly, hallucinations in Lewy body dementia often precede significant memory loss. This violates expectations about dementia and further delays recognition. Clinicians are trained to associate hallucinations in dementia with advanced disease. In Lewy body dementia, they may appear early. The preserved insight creates a false sense of safety. Because patients recognize hallucinations as unreal, they may not report them immediately. When they do, they often describe them matter-of-factly, minimizing distress. Clinicians may interpret this as benign or non-neurological. This is a mistake. Visual hallucinations in Lewy body dementia are not secondary features. They are core manifestations of cortical network failure. Their presence signals widespread synuclein pathology, affecting perception, attention, and inhibition. Treatment responses further reveal the nature of the problem. Antipsychotic medications, particularly those with dopamine antagonism, often produce severe adverse reactions in Lewy body dementia. Rigidity worsens, confusion deepens, consciousness fluctuates dramatically. In extreme cases, neuroleptic sensitivity can be life-threatening. This sensitivity is not idiosyncratic. It reflects underlying dopaminergic and cholinergic vulnerability. Blocking dopamine in a system already destabilized by synuclein toxicity precipitates collapse. The hallucinations may lessen, but the cost is catastrophic. This paradox reinforces misdiagnosis. When antipsychotics worsen the patient, clinicians may attribute the reaction to frailty or comorbidity rather than recognizing Lewy body dementia. The diagnostic signal is missed again. Over time, hallucinations may become more intrusive. As insight fades and network stability declines, hallucinations may be accepted as real. Emotional responses intensify. Fear, confusion, and behavioral disturbance increase. At this stage, the disease is advanced. The opportunity for early recognition has passed. The critical error is not mistaking hallucinations for psychosis. It is failing to ask why the hallucinations look the way they do. In Lewy body dementia, visual hallucinations are structured, recurrent, insight preserved early, and tightly linked to fluctuations in attention. This pattern reflects structural failure of visual integration networks, not primary psychiatric disease. They are diagnostic clues hiding in plain sight. The tragedy is not that hallucinations occur. The tragedy is that when they appear, the disease has already declared itself and is still ignored. Motor symptoms in Lewy body dementia often trigger a diagnostic pivot toward Parkinson's disease. Rigidity appears. Movement slows. Facial expression flattens. Gait becomes cautious. These signs look familiar. The problem is that they do not behave as Parkinson's disease does. This difference is not subtle. It is structural. Parkinson's disease is defined by relatively focal degeneration of dopaminergic neurons in the substantia nigra, leading to dopamine depletion within the striatum. The motor syndrome that follows is progressive but orderly. Tremor, rigidity, and bradykinesia evolve in recognizable patterns. Cognitive decline, when it occurs, typically follows years later. Lewy body dementia reverses this sequence. In Lewy body dementia, Parkinsonian motor features emerge in the context of already unstable cognition, fluctuating attention, hallucinations, and autonomic dysfunction. The motor system is not the first system to fail. It is one of many destabilized simultaneously. The underlying pathology explains why. Alpha-Synuclein toxicity in Lewy body dementia is diffuse. Dopaminergic neurons are affected, but they are not isolated. Cholinergic, noradrenergic, and serotonergic systems are compromised in parallel. Motor output is altered not just by dopamine loss, but by failure of multiple modulatory inputs that normally coordinate movement. This produces Parkinsonism that looks incomplete. Rest tremor is often absent. Rigidity may fluctuate. Bradykinesia appears inconsistently. Gait impairment may worsen under cognitive load rather than physical exertion. These features do not fit classic Parkinson's disease criteria, yet they are real. Clinicians respond by trialing dopaminergic therapy. The response is usually disappointing. Levodopa may produce minimal motor improvement and often worsens hallucinations, confusion, or agitation. The brain's dopaminergic system is not simply depleted, it is dysregulated within a broader network failure. Increasing dopamine in this context destabilizes cognition without reliably restoring motor control. This paradox is diagnostic. In Parkinson's disease, dopamine replacement improves movement predictably. In Lewy Body Dementia, it produces mixed or harmful effects. The nervous system cannot isolate motor benefit from cognitive cost because the disease does not respect system boundaries. Neuroleptic sensitivity further exposes the difference. Antipsychotic medications that block dopamine receptors are commonly prescribed when hallucinations or behavioral disturbances dominate the clinical picture. In Lewy Body Dementia, these drugs frequently produce severe reactions. Rigidity worsens dramatically, consciousness declines, autonomic instability increases. In extreme cases, patients develop neuroleptic malignant-like syndromes. This sensitivity is not an adverse drug reaction. It is a consequence of already fragile dopaminergic signaling layered onto diffuse synuclein toxicity. Blocking dopamine in this context removes one of the few remaining modulatory supports the nervous system has. The result is collapse, not improvement. Motor fluctuations mirror cognitive fluctuations. On some days, movement is relatively smooth. On others, stiffness and slowness dominate. These changes correlate with attention, alertness, and autonomic state rather than with structural progression. This reinforces misclassification as functional or medication-related rather than neurodegenerative. Importantly, motor symptoms in Lewy Body Dementia often appear after cognitive and psychiatric features. This temporal order violates diagnostic heuristics. Clinicians expect movement disorders to precede dementia in Parkinsonian syndromes. When this order is reversed, confidence erodes. The distinction between Lewy Body Dementia and Parkinson's disease dementia hinges on timing, but timing is rarely documented precisely. Cognitive complaints are often recognized only after functional impairment becomes obvious. Subtle attentional decline may have preceded motor symptoms by years without formal evaluation. This ambiguity allows mislabeling to persist. The motor system in Lewy Body Dementia is not failing alone. It is embedded within a destabilized network that includes attention, perception, and autonomic regulation. Movement cannot be isolated from cognition because the circuits that normally separate them are compromised. This is why treatment strategies fail. Medications designed for isolated motor dysfunction cannot restore balance in a system where multiple neurotransmitter networks are collapsing together. Each intervention shifts instability rather than resolving it. As the disease progresses, motor impairment deepens. Rigidity increases. Gait becomes unsafe. Postural instability worsens. Falls become frequent. Speech slows and loses modulation. Swallowing becomes impaired. These changes reflect cumulative network failure rather than progression of a single motor pathway. By this stage, diagnosis is often revised, but the revision changes little. The nervous system has already lost the capacity to respond adaptively. The disease is no longer ambiguous, it is pervasive. The central lesson of Parkinsonism in Lewy Body Dementia is not that motor symptoms occur. It is that they occur without obeying the rules clinicians expect. This rule-breaking behavior is not accidental. It is the signature of a disease that refuses to remain confined to one system, one neurotransmitter, or one diagnostic category. And by the time the motor system makes that clear, the disease has already passed its earliest, most deceptive phase. Long before Lewy Body Dementia is recognized as a cognitive disorder, it often announces itself through systems that are rarely linked back to the brain. These early signals are not subtle. They are simply misfiled. Autonomic dysfunction and sleep disturbance frequently precede cognitive decline by years. When they appear, they are treated as independent medical problems rather than as components of a unifying neurological process. This separation delays diagnosis more reliably than any imaging limitation. The autonomic nervous system is particularly vulnerable to alpha-synuclein pathology. Alpha-synuclein aggregates appear early in autonomic nuclei of the brainstem and peripheral autonomic ganglia. These regions regulate blood pressure, heart rate, gastrointestinal motility, bladder function, and thermoregulation. When they fail, symptoms emerge gradually and are often normalized as part of aging. Orthostatic hypotension is a common early feature. Patients report dizziness, lightheadedness, or near syncope upon standing. Blood pressure measurements confirm significant drops with postural change. These episodes may begin years before cognitive symptoms are noted. They are managed with hydration advice, medication adjustments, or cardiology referral. The neurological origin is rarely considered. Constipation is another early signal. Gastrointestinal motility depends on enteric nervous system function, which is affected early in synucleinopathies. Chronic constipation often predates diagnosis by a decade or more. It is treated symptomatically and never linked to later cognitive or motor decline. Urinary dysfunction follows a similar pattern. Urgency, frequency, and incomplete emptying are attributed to urological aging or prostate disease. Autonomic bladder control failure is not recognized as part of a neurodegenerative process until much later, if at all. These symptoms are not peripheral. They reflect early brainstem and autonomic involvement by alpha-synuclein pathology. They are biological signals that the nervous system is already compromised, even while cognition appears intact. Sleep disturbance is the most specific and most ignored of these signals. REM Sleep Behavior Disorder is strongly associated with Lewy Body Dementia and related synucleinopathies. In this condition, normal muscle atonia during REM sleep is lost. Dreams are enacted physically. Patients shout, strike, kick, or leap from bed while asleep. This is not insomnia. It is not nightmares. It is failure of brainstem circuits that normally suppress motor output during dreaming. REM sleep behavior disorder often precedes cognitive decline by many years. It may be present decades before diagnosis. Yet it is rarely connected to future neurodegeneration in real time. Sleep studies document the disorder. Treatment focuses on injury prevention. The neurological implication is deferred. The predictive value is extraordinary. A significant proportion of individuals with idiopathic REM sleep behavior disorder eventually develop Lewy body dementia, Parkinson's disease, or related synucleinopathies. This association is well established. Despite this, a REM sleep behavior disorder remains siloed within sleep medicine rather than integrated into neurodegenerative risk assessment. Sleep fragmentation compounds cognitive instability. Loss of restorative sleep worsens attention, executive function, and emotional regulation. In a brain already destabilized by synuclein toxicity, sleep disruption amplifies daytime fluctuation. This leads to misinterpretation as delirium, medication effect, or psychiatric illness. Autonomic instability further destabilizes cognition. Fluctuating blood pressure, heart rate variability loss, and impaired cerebral perfusion exacerbate attention deficits. Brief hypotensive episodes can produce transient confusion. These episodes reinforce the appearance of inconsistency that defines Lewy body dementia and confuses diagnosis. The critical error is treating these symptoms as unrelated. Each autonomic and sleep disturbance is managed in isolation. No single clinician sees the full pattern. The disease advances while specialties operate in parallel. By the time cognitive symptoms dominate, these early signals are often forgotten or recontextualized as comorbidities rather than precursors. This delay has consequences. Medications prescribed for autonomic symptoms may worsen cognition. Treatments for sleep disorders may interact poorly with dopaminergic or psychiatric medications. The nervous system becomes more unstable under layered interventions. When Lewy body dementia is finally diagnosed, these early features are reinterpreted in retrospect. The pattern becomes obvious only after the disease has progressed beyond its most deceptive stage. The tragedy is not that these signals are subtle. It is that they are clear, specific, and ignored. Lewy body dementia often begins outside the cognitive clinic. It begins in sleep labs, cardiology offices, gastroenterology consults, and urology visits. Each symptom is a fragment of a larger failure that remains unassembled. By the time the fragments are joined, the disease has already reshaped the nervous system. The diagnosis fails not because the disease hides. It fails because it speaks in systems medicine does not listen to together. Lewy body dementia is not difficult to diagnose because tests are unavailable. It is difficult to diagnose because the available tests are poorly matched to the disease's biology. Modern medicine relies heavily on objective confirmation. Imaging, laboratory values, and biomarkers are expected to anchor diagnosis. In Lewy body dementia, these tools frequently provide false reassurance rather than clarity. Structural imaging is the first failure point. MRI scans in early Lewy body dementia are often described as normal or showing only mild, non-specific changes. There is no early, dramatic pattern of focal atrophy comparable to hippocampal loss in Alzheimer's disease. Cortical volume may appear preserved. Ventricles may be normal. These findings are interpreted as evidence against neurodegeneration. This interpretation is incorrect. Lewy body dementia is a functional network disorder before it becomes a structural one. Alpha-Synuclein pathology disrupts synaptic signaling, neurotransmitter balance, and network synchronization long before neurons die in large numbers. MRI detects tissue loss, not synaptic failure. By the time atrophy is visible, the disease is advanced. Functional imaging offers limited help. PET and SPECT scans can demonstrate hypermetabolism or reduced dopamine transporter activity, but findings are variable and dependent on disease stage. Occipital hypermetabolism, when present, supports Lewy body dementia, but it is not universal. Dopamine transporter imaging may be abnormal, but similar findings occur in Parkinson's disease and related disorders. These tests increase suspicion, but rarely confirm diagnosis alone. Cerebrospinal fluid biomarkers further complicate the picture. In Alzheimer's disease, amyloid and tau profiles provide supportive evidence. In Lewy body dementia, alpha-synuclein is not reliably detected in standard clinical assays. CSF studies are often normal or nonspecific. When Alzheimer-type changes are present concurrently, which is common, results become ambiguous. Mixed pathology is the rule, not the exception. Autopsy studies show that many patients with Lewy body dementia also have amyloid plaques or tau tangles. Biomarker profiles may therefore suggest Alzheimer's disease, even when synuclein pathology is driving symptoms. Clinicians follow the test result rather than the clinical pattern. This misdirection delays recognition. Electroencephalography may show generalized slowing, but this finding lacks specificity. It may support the presence of encephalopathy, but does not identify cause. Normal EEG does not exclude Lewy body dementia. Blood tests offer no solution. There is no reliable blood biomarker for alpha-synuclein pathology in routine clinical use. Research assays exist, but they are not widely available or definitive. Routine laboratory work remains normal, reinforcing the illusion that symptoms are functional or psychiatric. The absence of confirmatory testing places heavy weight on clinical judgment. This is where diagnosis often fails. Medicine is trained to distrust diagnoses that cannot be supported by tests. When imaging is normal, biomarkers are equivocal, and symptoms fluctuate, clinicians hesitate to commit to a neurodegenerative diagnosis. The default becomes watchful waiting or alternative labeling. False reassurance is actively harmful. Patients are told that scans are reassuring. Families are encouraged to focus on mood, sleep, or stress. Interventions target symptoms in isolation. Meanwhile, Alpha-Synuclein pathology spreads. When tests finally become abnormal, the disease is no longer ambiguous. Cortical atrophy becomes visible. White matter integrity declines. Functional capacity collapses. The diagnosis becomes clear only after the opportunity for early recognition has passed. The problem is not that Lewy body dementia lacks tests. The problem is that the disease unfolds at a level tests are not designed to detect early. Synaptic failure, neurotransmitter instability, and network desynchronization do not leave immediate radiographic signatures. They produce symptoms before they produce images. This creates a diagnostic trap. Clinicians are taught to prioritize test results over narrative patterns. Lewy body dementia demands the opposite. The pattern is the diagnosis. The tests are supportive at best and misleading at worst. By the time objective confirmation arrives, the nervous system has already crossed critical thresholds of dysfunction and loss. The disease has not been hiding. The tools have been looking in the wrong place. Lewy body dementia does not become irreversible at the moment of diagnosis. It becomes irreversible when the brain can no longer compensate for distributed instability. This transition marks the point of no return. Early in the disease, alpha-synuclein pathology destabilizes networks without destroying them. Neurons remain alive. Synapses still function intermittently. The brain shifts workload across regions, compensating for local failure. This produces fluctuation periods of clarity, alternating with periods of impairment. Compensation has limits. As synuclein pathology spreads from brainstem and limbic structures into the neocortex, the nervous system loses redundancy. Networks that once supported each other begin to fail together. Attention, perception, motor control, and autonomic regulation no longer alternate in dominance. They collapse in parallel. This convergence defines the transition. White matter connectivity begins to deteriorate. Axons connecting cortical and subcortical regions lose trophic support as neurons degenerate. Synaptic failure becomes structural. Communication slows and fragments. Timing between regions fails. The brain can no longer synchronize activity across domains. At this stage, fluctuation diminishes, not because the disease has stabilized, but because there is no longer enough intact network to fluctuate. Clarity disappears. Cognitive decline becomes continuous. Attention no longer recovers. Executive function does not rebound. Insight fades. The patient may still recognize familiar faces or environments, but complex processing is lost. The disease now resembles a global dementia. Motor function deteriorates alongside cognition. Parkinsonian features intensify. Rigidity and bradykinesia dominate. Gait instability worsens. Falls become frequent. Speech slows and loses modulation. Swallowing becomes unsafe. These changes reflect loss of integrated motor control rather than progression of a single pathway. Autonomic failure accelerates decline. Blood pressure instability worsens. Syncope becomes more frequent. Thermoregulation fails. Gastrointestinal dysfunction deepens. These changes further impair cerebral perfusion and metabolic stability, accelerating network failure. Neuropsychiatric symptoms change character. Hallucinations may persist, but insight is lost. Illusions may form. Emotional responses flatten or become inappropriate. Apathy replaces anxiety. Behavioral disturbances become less reactive and more pervasive. This shift reflects cortical involvement. As frontal and association cortices lose function, self-monitoring disappears. The patient no longer recognizes deficits or danger. Supervision becomes necessary for safety. Imaging at this stage reveals widespread damage. Cortical atrophy becomes visible. Ventricles enlarge due to tissue loss. Occipital and parietal regions show hypometabolism. White matter volume declines. These findings confirm a process that has already passed its critical threshold. At this point, diagnosis becomes obvious. It also becomes irrelevant to outcome. No treatment can restore network integrity. No medication can reassemble lost connections. Symptomatic management may reduce distress, but it cannot change trajectory. The disease has moved beyond instability into structural disintegration. This is the biological endgame of Lewy Body Dementia. The disease no longer pretends to be something else. It no longer fluctuates or misleads. It declares itself fully when nothing can be done to reverse it. The tragedy lies in timing. For years, the disease announces itself through instability, hallucinations, sleep disorders, autonomic failure, and inconsistent motor signs. These signals are ignored or misclassified. By the time the pattern is undeniable, the brain has already lost the capacity to compensate. The point of no return is not a single moment. Once crossed, the nervous system cannot recover coordination. Networks that once flickered between failure and function are permanently offline. The disease has finished disguising itself. What remains is irreversible collapse. After Lewy body dementia crosses the threshold of network collapse, the disease enters a stable aftermath. Progression may continue, but the nature of decline no longer changes. The nervous system has lost the structural capacity to regain coordination, stability, or reliable function. At this stage, treatment options are limited and clearly bounded. There is no disease-modifying therapy that halts alpha-synuclein pathology. No intervention reverses synaptic loss, restores network synchronization, or clears established Lewy body burden from the brain. Management becomes supportive rather than corrective. This distinction matters. Medications may reduce specific symptoms, but they do not repair the underlying failure. Cholinesterase inhibitors can modestly improve attention or reduce hallucinations in some patients, but benefits are partial and temporary. Dopaminergic therapies may provide limited motor relief, but often worsen cognition or psychosis. Antipsychotics remain dangerous due to neuroleptic sensitivity, even late in the disease. Every treatment is a compromise. The nervous system no longer tolerates pharmacologic stress well. Small changes produce disproportionate effects. What improves one domain destabilizes another. Care becomes an exercise in minimizing harm rather than restoring function. Daily life reshapes around dependence. Cognitive decline becomes continuous. Attention does not return. Executive control is absent. Memory becomes unreliable. The patient may still recognize familiar people or environments, but integration of information is lost. Decision-making is no longer possible. Supervision becomes constant. Motor decline compounds disability. Rigidity and bradykinesia limit mobility. Falls are common. Speech becomes reduced and difficult to understand. Swallowing impairment increases the risk of aspiration pneumonia. Nutrition declines. Fatigue dominates daily experience. Autonomic failure continues to erode stability. Orthostatic hypotension produces recurrent dizziness and syncope. Urinary and bowel dysfunction require ongoing management. Temperature regulation becomes unreliable. These failures further weaken physiological resilience and accelerate decline. Neuropsychiatric symptoms stabilize into a fixed pattern. Hallucinations may persist, but insight is often lost. Emotional responses flatten or become inappropriate. Apathy replaces anxiety. Behavioral disturbances become less reactive and more pervasive. Personality changes reflect loss of frontal and limbic regulation rather than psychological adaptation. Care shifts from independence preservation to safety. Environmental modification, mobility assistance, and feeding support become central. Speech and occupational therapy focus on maintaining communication and preventing injury rather than skill recovery. palliative approaches increasingly guide decision-making. The diagnosis, once elusive, is now unquestionable. But clarity arrives too late to alter biology. Lewy body dementia does not end in uncertainty. It ends in structural absence. Networks that once fluctuated have collapsed. The brain no longer functions as a coordinated system. Awareness fades not because identity disappears, but because the machinery required to express it is gone. This outcome is not the result of missed opportunities for cure. It is the result of delayed recognition of a disease that resists classification. Lewy body dementia is not rare. It is not subtle. It is not benign. It is a disorder that announces itself early through instability, hallucinations, sleep disturbance, autonomic failure, and inconsistent motor signs, and hides behind diagnostic hesitation. The fear in this disease is not fear of memory loss alone. It is the fear of a disorder that looks like many things, is treated as many things, and is recognized only when it can no longer be changed. This is pathology of fear, not because the disease is unpredictable, but because it is predictable and still missed. And this fear is real.